Would you stand up?
Hello.
Sometimes, she's also American now, by the way, but sometimes we still eat Canadian. We have maple bars and things. No, no, I was just kidding. I have quite a few family and friends in Canada, and Canada's ahead of us in this regard. Canada's palliative care is much more extensive and better developed. It does vary by regions and by provinces, but in Montreal and Quebec it's very strong. Actually, Ontario is pretty strong. BC is quite strong. The models change a little bit from place to place. In BC, it's more of a hospice model, but it's better financed because it's universal health care. And the deal is that better care is actually less expensive because you prevent crises, you have continuity, you anticipate needs before people find them. That people don't have to feel like they're the first person on a planet to ever go through this as an individual or a family. So it actually lines up very well, and the provincial governments have figured this out. And a lot of the early work in developing programs came from Canada. Yvonne Corbet here, I met because she was at McGill in the leading palliative care, academic palliative care program in North America back in the, I won't tell you what decade, but it was a long time ago. So yeah. Jana's going to make us stop. Oh.
You mentioned at the beginning.
Hi, Donna.
Hi, at the beginning of your talk about your No One Alone volunteers.
Yes. Sure. So the No One Alone volunteers. So I mentioned that what we came to Dartmouth to try to give one more national example of a palliative care program that was built on a full-service hospice model. The true interdisciplinary team, physicians, nurse practitioners, nurses, social work, chaplain, and we wanted healing arts, massage, Reiki. We have a writer who pulls poems out of people. We have music therapists or music, not thanatologists, but somebody who does play harp and engages people in played music, and we have a graphic artist who helps people paint little watercolors and like. But part of that was we felt we needed volunteers, and so we have now 35 or more trained volunteers who simply sit with people within the hospital, visit. They deliver newspapers to people in the morning. It's good for boredom, also good for constipation, by the way. They'll just sit with people, kibitz with people. I've given them the 3 charges to combat isolation, loneliness, and boredom. 3 factors that erode quality of life when people are in the hospital, particularly for long periods of time. This we can fix, or at least ameliorate. Isolation, loneliness, and boredom. What we do, by the way, we train them. It's a long training. We're just doing it right now, actually. There's a 6-week training going on right now. At the ceremony, the graduation ceremony, we play pomp and circumstance. It's really cute. We hand them a diploma. But I also tell them that now, given that you've been screened and trained and will be supervising you, you have a license to love. You can go out and just sit with people. You can kibitz with people. You can read them the newspaper. If they're not NPO, you can get them a treat. Whatever it is, just to humanize what is often a very difficult environment for people. So that's what, and we call them the No One Alone volunteers. Oh, you can't turn down George.
Yes.
Sir.
Yes, I'm wondering if there's any chance legislation would help us to catch up with Canada.
Well, legislation would help. Legislation can't do all of it, but it could do some things. It could get rid of the arbitrary either-or model of disease treatment or hospice care. I mean, that was based in the Medicare statute that was passed in 1981. It was based on the assumption that if you provided full hospice care and full disease treatment, it would be too expensive. Okay, that was logical. We now have good data that proves it was wrong. that actually if you force people to choose between disease treatment and hospice care, they just come to hospice care very late. They still get treatment. That's part of why over 50% of people die in hospitals and 20% of people die in ICUs, because they come to hospice care very late. The length of stay in hospice care, the median length of stay, has actually fallen from 22 to now 19 days. Okay? So, that we're doing brink of death care. We could also use public policy to change staffing in nursing homes. We could start to pay the nurses and the nurses' aides in nursing homes a living wage. I mean that. I mean, that's one of the bedrock problems. You can't staff nursing homes. Nursing homes are about, half to 2/3 what is felt to be safe staffing. And it's just every study that's done shows that, and then it makes a news cycle for one cycle, and then everybody forgets about it. But we could actually increase that, and it probably wouldn't cost a dime more, because the more staff you have, the less people end up getting shipped to the hospital when there's a problem. They keep them there, and they care well for them there. Third, I would say, and then I'll stop, is I could keep going, but we actually need legislation to change medical education, because politically, I can't get more curriculum hours from the Department of Obstetrics and Gynecology, who is still teaching 200 hours or more of obstetrics to every medical student, whereas almost no very few doctors deliver babies, and everyone who has done a family practice or OBGYN residency after they got out of medical school, right? And oh, by the way, last I checked, only 50% of the population was at risk for having an obstetrical experience. So if I want 100 hours, of that, split the difference and give me 100 hours to teach palliative care and hospice, we could do that, but I can't get it through a curriculum committee. I need a legislature to say this has got to happen. We have an aging population. We have a chronic illness is expanding exponentially. We need to teach medical students how to care for an aging population with chronic illness. Duh. But it's not going to happen at the medical school level. I'll tell you, it has to happen at a social level where we boomers take back the end of life. Anyhow, you got me on a roll now. Thank you. Thank you.
I want to get everybody downstairs.
Okay. Thank you very much for being here.